Vedanta. Okay.
Very good morning to one and all. I'll be presenting a case of acquired accommodation and convergence insufficiency post-traumatic brain injury. This study does not receive any specific funding, fee or support. Introduction. Traumatic brain injury refers to the resulting of physiological disruption of brain function after any external force impact on the head, which may or may not be associated with structural damage to the brain. Accommodative insufficiency and convergence insufficiency are some of the most common visual problems following a traumatic brain injury. In the light of increased prevalence of traumatic brain injuries following road traffic accidents or combat sports, it is important for clinicians to be aware of the associated visual symptoms and methods of diagnosis and treatment. We describe a case of acquired accommodation and convergence insufficiency post-traumatic brain injury and its management. A 32-year-old male patient presented to us with a history of road traffic accident and traumatic brain injury. He presented to us 1 month post-trauma with complaints of blurred vision and difficulty in reading and focusing on nearby objects. There was no history of diplopia, headache, no ocular deviation prior to trauma, no history of spectacle usage or ocular surgery prior. There was no significant past or family history. The old MRI report post-trauma showed diffuse axonal injury of grade 3 in the midbrain and bilateral thalami. On general examination, the patient was conscious, well-oriented. Systemic examination, CNS examination, there was right hemiparesis, but the patient was able to ambulate without support. On ocular examination, head posture was erect. Hirschberg test showed left exotropia of 15 degrees. The EOM was full and free in all gazes, in both eyes. On slit lamp examination, vision, refraction, anterior segment and fundus was normal. On detailed orthoptic evaluation, the stereopsis was 100 arc seconds. The Worth 4-dot test, there was left suppression with occasional fusion. There was, on cover test, there was exotropia. The near point of convergence, there was a reduction and it was not converging. The near point of accommodation was reduced. The MEM retinoscopy, they showed a lag of accommodation. The PRA was reduced and the positive fusional version was also reduced. Accommodative facility was also found to be reduced. We came to a diagnosis of convergence and accommodation insufficiency with acquired exotropia secondary to traumatic brain injury. The treatment we initiated was a vision treatment therapy. There was in-office vision therapy and also a home therapy. In office therapy, we trained the convergence. Considering that patient complained of double vision at 40 centimeters, we incorporated an exercising prism in trial frame and asked the patient to fuse the pen tip. As and when the patient was able to fuse at the earlier distance, the target distance was slowly reduced from 40 to 35 centimeters, and the process was repeated again while reducing the exercise prism from 5 base out to 2 base out. For training of accommodation, the patient was trained to perform heart chart and accommodative flippers with an N12 target. For home vision therapy, the patient was prescribed eccentric circle training and the patient was able to converge for 10 seconds with a 10 base out exercising prism. Accommodative flippers was also prescribed. The patient was asked to wait for 6 months for improvement and plan for surgical correction if necessary. On follow-up after 1 month, it was found that the patient had significant improvement in convergence and also mild improvement in accommodation. These are pictures showing the same. Our discussion. Oculomotor symptoms following traumatic brain injury may include blurred vision, convergence insufficiency, difficulty in reading. It is very necessary to diagnose these patients because many of these patients, if treated with proper visual therapy, will improve without the need for any surgery.
Hospital-based exercises you did now. How long you did for that?
The patient was asked to come back on weekly basis, ma'am.
Okay.
So he came back and we were giving him in-office therapy.
Weekly based once and then home therapy.
On and home therapy.
Okay. How long it took to recover actually?
In 1 month, the recovery we saw was in 1 month. We had follow-up. Patient is asked to follow up every month.
So exotropia first it was there and then Next pictures, exotropia was not there.
It reduced
Reduced.
significantly,
Is there any pupillary dilatation in this
There was no
patient?
pupillary involvement, ma'am.
And even at follow-up, his NPA is still only at 13. Have you given any plus classes for this patient?
No, ma'am. He was
Great.
able to read without glasses, plano. So we did not prescribe any glasses.
Okay. And have you planned for surgery or?
We
what
want
is
to
your
see the
plan?
improvement, ma'am. We want to wait for 6 months, and then if there's complete improvement, we want to do this.
Prism glass you prescribed or you asked only for the
Only
hospital?
for training.